Assalamu alaikum and good evening. So today we will discuss on hypertension, and thanks Axis Medical School for inviting me to talk something about hypertension. Hypertension is actually large chapter. So I think we should have more classes, at least 3 or 4 classes. So today I think the first class on hypertension. And actually, we want to discuss hypertension through some cases, actually case-based, and there should be some evidence-based also. As now our practice to treat the patients with hypertension are all suffering from any diseases. Actually, it should be on evidence-based also. So this is the first case. So this is the first case on hypertension. So through this case, we want to solve the problems of this patient. And we also learn how to approach a patient with hypertension also. So this is the case scenario 1. Mr. Someone who is 40 years old, businessman, presented with headache, neck pain, and dizziness for last 15 days. He's a smoker and dyslipidemic. His blood pressure is 155 over the 95 millimeter marker on both arms, and pulse is around 80 beats per minute. So what should be the next management strategy regarding this hypertension? So here we'll get some features of hypertension, that is some symptoms of hypertension like headache, neck pain, and dizziness. This patient have headache, neck pain, and dizziness also, and he's around 40 years old, that is middle-aged person. And he's suffering this type of symptoms for the last 15 days. And he's also smoker and dyslipidemic. And this is actually some other risk factors of ischemic heart disease also. We all know that hypertension is a risk factor for ischemic heart disease. And he has another 2 more risk factors like smoking and dyslipidemia. And his blood pressure is 150 over 55 over 95 millimeter mercury. So he is hypertensive. You all know that to define hypertension, if a patient has blood pressure over 140 systolic and diastolic is over 90 millimeter mercury, so he is designated as hypertension, or he is labeled as hypertension. As this patient has 155 over 95 millimeter mercury, so his systolic pressure and diastolic pressure, both two types of pressures are raised above the range, so he is hypertensive. And his blood pulse is also 80 beats per minute. So pulse is always important. When you will treat a patient with hypertension, you have to always to keep eye on the pulse also, because it's another factor. Pulse is also another factor for guiding our patients also. Not only blood pressure, pulse is also important here. So we have to think before the management. We have to staging the patient of this hypertension of this patient. So we have to know what is his stage of hypertension. So we'll have a classification of hypertension later on, and we also have some questions before treating the patients: role of lifestyle modification, role of diets, and what are the first line antihypertensive. We have to know that what the first line of hypertensive, and we also have to know that what are the role of diets or what the role of lifestyle modification to control the hypertension also. So before managing a patient with hypertension, we have to have consider some points regarding number 1, what is the stage of hypertension. So we always keep in memory the classification of hypertension always. So we have to know the classification of hypertension also. So depending on the classification of the hypertension, that is staging of hypertension, our treatment strategy, that depends. Because if the patient has mild hypertension or grade 1 hypertensive drug, grade 1 hypertension, he needs 1 or 2 drugs actually. I mean, at least one drug or lifestyle modification may be enough to treat the hypertension. If patient is stage 2 or stage 3 hypertension, stage 2 hypertension usually we start with 2 drugs, and when a patient is suffering from grade 3 hypertension or stage 2 hypertension according to the NC8 guideline, he may need 2 or 3 more antihypertensive drugs actually with in optimum doses also, along with lifestyle modification, along with dietary approach to stop the hypertension, that is along with DASH diet also. So we have to, we should know the in which stage now the patient has. So staging of hypertension is important. The second point is what are the compelling indications if this patient has got any compelling indications. So we should know what are the compelling indications. Compelling indications means in which situation we actually compelled to a specific drugs or a specific group of drugs actually, like if the patient has got proteinuria, or the patient has got diabetes mellitus, or if the patient has kidney diseases, he or she should be added ACE inhibitor ARB as the first line drug. So this group of drugs should be prioritized because this group of drugs retarded or halt the progression of the chronic kidney disease, or the revert the proteinuria, or it reduces the proteinuria also. And we also know that diabetes, if the patient is suffering from diabetes, so this patient may be at risk of diabetic nephropathy, or if the patient is also suffering from diabetic nephropathy, this patient should get ACE inhibitor ARB as the first line of drug. So these are the actually compelling indications in that cases. If the patient is suffering from ischemic heart disease, in that cases, though beta blocker is not a first line antihypertensive drug, we all know that what are the first line antihypertensive drug? ACE inhibitor or ARB, calcium channel blocker, and diuretics. These are the 3 groups of drugs, either ACE inhibitor or ARB, anyone from these 2 groups, and calcium channel blocker and diuretics. These are the 3 or 4 groups that are the actually first line antihypertensive drugs. That is, we should start this group of drugs when the patient is first diagnosed as the hypertension. So if the patient is suffering from beta blocker, suffering ischemic heart disease, in that case, patient should be added, or patient should be started with beta blockers along with other antihypertensives. So in that cases, beta blocker, these are the here ischemic heart disease with hypertension is compelled to add the beta blocker actually. Though beta blocker is not first line antihypertensive drug, but if the patient has ischemic heart disease, in that case, we should start with a beta blocker also. So this is the importance of compelling indications here. So drug of choice, that is also important. In some situation, we have to choose some drugs. Like if the patient is that is not well to do enough, that is patient is not well off, patient is poor, in that case is actually we should choose some drugs or antihypertensive drugs in low cost antihypertensive drugs also in that cases. Or in that cases, if the patient has is aged patient, that is and he or she, he had a benign enlargement of prostate also, that is prostate enlargement. In that cases, actually we should choose the drug like alpha blockers. That is the prazosin group of drugs we should choose. And any target organ damage, when we consider antihypertensive management, either the patient is suffering from hypertensive emergency or hypertensive urgency, to classify it or to define it, we have to see the target organ damage. Or if the patient has got target organ damage, in that case is actually we have to treat the hypertension actually very carefully and very strictly also. We have to control the hypertension. What are the target organ damage actually if a patient suffering from hypertension? And this hypertension may damage our brain, may damage our kidney, may damage our heart, or may damage our eyes, and also the blood vessels. So these are the 5 organs: brain, kidney, heart, eyes, retina, and blood vessels. And these are that is when patient is not treated hypertension enough, that is patient has uncontrolled hypertension for a long time, so there may be damage of this target organ like brain, kidney, heart, and retina, and also blood vessels. And the another point is we have to see is there is any contraindications or not. So this is a very important point when we consider the patient with hypertension. If a patient is suffering from bronchial asthma, so in that cases actually we should avoid the non-selective beta blocker, especially propranolol and other groups of drugs. These groups of drugs, non-selective beta blocker, can enhance the asthma attacks. So we have to avoid the beta blocker in a patient with hypertension. Suffering from hypertension. So beta blocker is contraindicated there. If the patient is suffering from peripheral vascular disease, in that case, it is also contraindicated of the beta blockers. In that case, we should not give beta blocker. Or if the patient has got low pulse rate, that is less than 60 or less than 50 beats per minute, so we have to actually there is some contraindication of the rate-limiting antihypertensive drugs like beta blockers, like calcium channel blockers, especially diltiazem or verapamil groups of drugs actually that acts on the AV node and reduce the pulse also pulse further. So we have to in that cases we have to there is some contraindications, that is we have to avoid the beta blockers or calcium channel blockers, especially rate-limiting calcium channel blockers like diltiazem and verapamil. We should be avoid in a patient with low pulse rate. So there are also some other drugs that are indicated, especially patient is if the patient has especially female patient, in case of female patient having pregnancy, during pregnancy, we all know that ACE inhibitor and ARB, these are the contraindicated in a patient with pregnancy. So we have to consider the contraindications when we have to treat the patient with hypertension. So this is the another next factor is white coat effect. So what is white coat effect? White coat effect is that when a patient came to doctor's chamber or hospital or any clinic, if his or her blood pressure is raised, that is patient is diagnosed as hypertension, that is in the hypertensive level. But patient says that, sir, my blood pressure, when we measure blood pressure in home, my blood pressure is normal. My son or my daughter is a doctor, or my son or daughter is skilled to measure the blood pressure, or we are also skilled to measure the blood pressure, or we have skilled personnel to measure the blood pressure, and they always measure our blood pressure or my blood pressure, and we found that there is always blood pressure is normal in the home environment. So patient may say that, so I don't understand why my blood pressure is raised here. So in that cases, if a patient has normal blood pressure in home, but in office measurement, that is in chamber, if the blood pressure is high, that is patient is diagnosed as a hypertensive, in that this may be an effect of white coat effect. So we call it white coat effect. In that cases, actually, we should start antihypertensive disease cautiously, and we have to cautious about the initiation antihypertensive drug of this patient. So, but at first, we have to confirm this patient has got white coat effect or not, and actually, this patient is hypertensive or not. Because if we give antihypertensive drug to a patient actually normotensive, blood pressure may goes down and patient may have suffering from hypertension, or patient has got some symptoms of a low blood pressure. So we have to confirm this that either this patient has got any white coat effect or not. So white coat effect is important. And another point is the right technique of blood pressure measurement. This is very, 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 very important, because we have to initiate the drugs according to the patient blood pressure measurement, that is blood pressure. We have to set in which stage the patient is now, and right technique of blood pressure is important. And for follow-up of the patient, either the drug is working good or not, or one or two drug is enough, or the drug the patient is taking or the drug patient is receiving is enough to control his blood pressure or not. And that depends on the right technique of the blood pressure measurement. So right technique of blood pressure measurement is important to at least at first to diagnose the hypertension, to initiate the drugs, and also to follow up the patients according to the blood pressure chart. So it is important to measure the blood pressure in the right way. So also we have to see if the patient has got any secondary causes. Actually, when a patient is getting one or two antihypertensive drugs, but still this patient not controlled by these drugs, so in that cases, we always search for secondary hypertension. Though when the patient first comes to our chamber, and when the patient comes to the hospital to assess his blood pressure, in that cases, actually, we have thoroughly assessed this patient. And actually, I will discuss how a patient of hypertension should be assessed thoroughly. I will discuss it later on. So in that case, a patient should be assessed thoroughly, and we always have to see if the patient has got any secondary causes or not. Any secondary cause, or to see the patient has why the patient blood pressure is not controlled enough by one or more than one or two drugs. We have to see there are a lot of secondary causes. If we don't control the secondary causes or don't treat the secondary causes properly, this patient blood pressure may not be controlled by 1, 2, 3, or 4 or 5 antihypertensive drugs. So patient, we have to see the any secondary causes actually before starting the treatment, actually when you assess the patient with hypertension. So hypertension diagnosis is very easy, but to start its management, it is always to be cautious. It is always to be very, very alertful to start the antihypertensive drugs, and also to start the lifestyle modification also. Though any patient can get the lifestyle modification, but before starting a drugs, we should always be cautious and to confirm if he or she has got any secondary causes or not. And we will discuss later on the details of secondary causes of hypertension. And so these are another factor is the age of the patient. Age of the patient is very important because when patient is at advanced age, patients artery actually these are becoming hardening day by day with ages actually, and the patient blood pressure is usually systolic blood pressure usually raised, and some drugs may not work properly in a patient with hypertension in an aged population also. So we have to choose some antihypertensive drugs for the aged people, like calcium channel blockers or like diuretics, thiazide like diuretics. Actually, this group of drugs is actually work better for a patient, in aged patient, actually more than 60 or 65 years old, because their artery is more hardened than the younger ones. So age of the patient is important here, and a patient with systolic hypertension in a case of actually aged population, we have to consider some special groups of drugs to control the blood pressure. Race and ethnicity of the patient is also important, though it is not actually applicable in our country, because in cosmopolitan area, cosmopolitan city, especially when there is multi-ethnic population is living, in that cases, actually this is important. We all know that in Black people, ACE inhibitor or ARB group of drugs is not work properly. So in that cases, especially in Black population, we should avoid ACE inhibitor ARB. Otherwise, it is not. It is indicated. In that cases, if the patient in a Black people, if he or she has hypertension along with kidney diseases or along with diabetes or along with proteinuria, in that cases, ACE inhibitor ARB should be given along with the as a first-line antihypertensive drugs if they had got some compelling indication. Otherwise, a patient only hypertensive, a Black people, in that cases, ACE inhibitor ARB should be avoided in that group. So actually, these are the very, very important points to consider before the starting of antihypertensive or before managing a patient with hypertension. So these are the, we have to always remember these points before starting the antihypertensive. So if we continue the case scenario, this is the first case scenario. That is, patient was being treated with beta blocker at around 50 milligram once daily. And after 10 days, patient came for follow-up. Now pulse is reduced to 70 beats per minute, and blood pressure also reduced by 140 by 95 millimeter mercury. But as the patient is a young male of 40 years old, so he complains of erectile dysfunction due to beta blocker. So, so what is the criticism of this case scenario of this patient? As the patient is getting the beta blocker at the first line of drugs, though the patient has got no history of ischemic heart disease. So actually, this group of drugs should not be added as a first line drug. So we all know that first line drug should be calcium channel blocker, diuretics, or ACE inhibitor or ARB. This is the 4 groups of drugs of the first line antihypertensive. So actually, giving the beta blocker is not appropriate here. And also, as the patient has got also erectile dysfunction, though his blood pressure is reduced and his pulse is also reduced, but now actually we should withdraw this beta blocker due to erectile dysfunction. So what should be the next discussion here? Next management. So considering symptoms decreased, BP not controlled yet, and this patient is suffering from erectile dysfunction. So we have to avoid this beta blocker in this particular patient actually. And then what should be the next choice actually? So his beta blockers are stopped, and he switched to the calcium channel blockers like amlodipine, and advised to follow up after 2 or 3 weeks, and to monitor his blood pressure also by automated blood pressure measurement technique. Actually, this automated blood pressure measurement technique is now recommended to measure blood pressure and to record blood pressure also in the home environment. So it is now recommended by American College of Cardiology, American Heart Association, as well as European Society of Cardiology. So after giving the beta calcium channel blocker, his pulse is 80 beats per minute. Blood pressure is now controlled, 135 over 85 millimeter mercury. But patient now complained of ankle edema. So instead of giving beta blocker, that is atenolol, we switch to calcium channel blocker like amlodipine. This is the first line antihypertensive drug, but this patient has got some adverse effects like ankle edema, and the patient complained of ankle edema. So what should be actually our next management of this patient actually. So after considering the though blood pressure is controlled enough, but patient has got ankle edema, so we should now what should we give? So we should give to another groups of drugs, or we can stay on the another calcium channel blocker that has got minimum or no effect on ankle edema, like cilnidipine or like L-amlodipine, that is another group of new amlodipine, that is levoamlodipine is also called. So we can switch over to these drugs, or we can switch over the groups also, or we can add another drugs to combat the edema, to reduce the edema also. So we should switch over to another drugs like SC inhibitor, BRB, and these are also the first line of drugs, or we should give diuretics to reduce the edema, and then we have to follow up the patients to control the blood pressure, or to just adjust that antihypertensive drugs actually. So now this is the case scenario, and this we had already discussed the important considering points before starting the antihypertensive drugs. Now some thing about the hypertension. There's some discussion about the hypertension. So what is the definition of hypertension here? So hypertension is a hemodynamic disorder, and a well-accepted definition of hypertension was suggested by Evans and Rose. This is the Evans and Rose anti-hypertension definition, I think, and to me actually, to be honest, I think this is the best definition of the hypertension actually. The hypertension should be defined in terms of blood pressure level above which investigation and treatment do good more than harm. That is, this is the level above which, if we don't control or don't treat or don't level as the hypertension, the patient may have harmful condition, that is, may have target organ damage if we don't treat the patient. So hypertension should be defined in blood pressure above which investigation treatment do more good than harm. So this is the actually definition of hypertension, and according to the different guidelines in the past several years, like guidelines given by the JNC 8, JNC 7, JNC 6, or guidelines given by the American Heart Association, American Society of American College of Cardiology, and the European Society of Cardiology. There are several disputes actually. There are several different they have different comments about the hypertension actually. So according to the different guidelines, the classification of the guidelines actually varies, and so they have some different recommendations also. So this is the prevalence of hypertension. The prevalence of hypertension varies considerably by country: 20% in the USA, 25 to 50% in different regions of European countries. The exact prevalence of hypertension is still not known here, but in 1976, the prevalence was 1.10%. But in NCD, the 2010, according to the NCD 2010, the prevalence of hypertension is around 17.9% in general, and 18.5% in men, and 17.3% in women. That is around 20% in also in our country. So hypertension is probably more common in elderly population. We all know that with advancing age, there is increased chance of having hypertension, because there is an increased chance of development of the hardening of the artery. So that's development of the hypertension. And in one study, 65% in general, 75% urban area, and 53% in rural area. That is, hypertension is more prevalent in the urban area, in the cities actually, and less prevalent in the 53% that is rural area. We also know that there are some factors that can influence for the development of the hypertension. Actually, primary causes of hypertension. That is essential hypertension. We all know that stress, that is the competition, that's different types of type A personality that can lead to the development of the hypertension also. So according to the stress having the people or people having the stress in different regions, so hypertension and prevalence is also varies. So it is more in the cities area than in the village areas also. And these are the actually cardiovascular risk factor, that is risk factors for the atherosclerosis also. There may be some modified risk factor, there may be some relatively fixed risk factors. Modified risk factors means we can modify these risk factors, so we can control these risk factors, and we also control our or to reduce our risk of ischemic heart disease or to reduce our development of the atherosclerotic plaque also. So what are the modified risk factors? These are the cigarette smoking, and even maybe secondhand smoking also, or passive smoking may contribute to the development of the atherosclerotic cardiovascular disease. Where diabetes mellitus, uncontrolled diabetes mellitus, dyslipidemia or hypercholesterolemia, overweight or obesity, physical inactivity or low fitness, and unhealthy diet. These are the actually modifiable risk factors, because we can modify this factor, like we can modify our diet, we can do exercise, we can be more active, we can reduce our weight, and we can control our cholesterol level by drugs, and we can control by diabetes, and we can quit cigarette smoking, and along with hypertension also, this the risk factor, we can control our hypertension. And what are the relatively fixed risk factors? That is, it is difficult to modify, like chronic kidney disease, like family history. If our mother or father has got family history of hypertension, that is actually increased chance of having hypertension to their children also. That is increased age, that is with increasing age, that is increased chance of having atherosclerotic cardiovascular disease. There's a low socioeconomic educational status. These are the actually involved with having atherosclerotic cardiovascular disease. Male sex, male is more predominant or more vulnerable to have atherosclerotic cardiovascular disease than female. Actually, before the menopause, actually, obstructive sleep apnea. So obstructive sleep apnea is relatively risk factor, relatively fixed risk factor, because obstructive sleep apnea, if we control our weight, we can reduce. If we can reduce our weight, obstructive sleep apnea usually improves. So this is a relatively fixed risk. And psychosocial stress. This is also a stress where we can actually control some degrees of our psychosocial stress. So these are the factors that is relatively risk factor, not only fixed, that is relatively fixed risk factors of the having atherosclerotic cardiovascular disease. So this is the hypertension in Bangladesh. We will see this chart here. In 1995 to 2000, the prevalence of diabetes was 3.8%, but hypertension was around 11%. In 2001 to 2005, the type 2 diabetes it is a relative a bit increased to 5.3%, and but hypertension is around 12.8%. And in 2006 to 2010, the prevalence of hypertension increased to 9%, and hypertension around 15%. That is, but now actually the hypertension incidence prevalence is around 20%, and also diabetes around 10 to 12% actually. And we also we have discussed that in urban area, that is in people living in cities have more chance to having hypertension than rural peoples. This is the scenario actually when you consider the patient compliance in Bangladesh. This is the scenario, and this is pie chart. Actually, this pie chart showed how percentage of people suffering from hypertension is treated and controlled, or how much population is treated but not controlled, and how much population, how percentage of population actually not actually untreated, but they have hypertension. So around 25%, that is 1/4 of the population suffering from hypertension is usually treated and they are properly treated, and their hypertension are controlled. But around 44% of the hypertensive population, they have got treatment, but their blood pressure is not controlled enough. So this may be due to some different causes like non-compliance, and there are some other causes. And we will discuss the later on why this group of a large group of populations, around 44%, is not, their hypertension is not, why not controlled. And around 31%, that is the portion with yellow color, around 31%, the patient, they even did not get any treatment of hypertension. Even this patient may don't have, they are not aware, even they are aware of the hypertension. That is 31%. Even they are not, they have not got the antihypertensive medications. And when we consider this classification of the hypertension, this is the JNC 6 and JNC 7. So here we also see what are the difference between the JNC 6 and JNC 7 guideline to classify the hypertension. JNC means Joint National Committee. It is a 6 and JNC 7. When we see that in JNC 6, the optimum blood pressure was 120 or below 120 or over 80 millimeter mercury. Systolic blood pressure 120 and diastolic 80 millimeter mercury. Below this, it was normal. In JNC 7, this optimal is now called normal. And in JNC 6, the 120 to 129 systolic and 80 to 84 millimeter mercury, it was said normal, but normal is now below according to the JNC 7 level. There was borderline hypertension around 130 to 139 and 85 to 89. That is the before the hypertension, there was 3 categories according to the JNC 7 guideline. That was optimal, there is normal, and there is borderline. But according to the JNC 7 guideline, the optimal is become to normal, and this normal and borderline, that is patient having blood pressure 120 to 139 systolic blood pressure, and diastolic blood pressure is 80 to 89. It is labeled as pre-hypertension. So it is pre-hypertension, that is less than 140 and less than 90. That is, it is pre-hypertension. And why this hypertension? If the blood pressure is 140 over 90 millimeter mercury, that's equal to or more, this is called hypertension. And what is stage 1, stage 2, and stage 3 hypertension? In stage 1, 140 to 159 systolic and 90 to 99 millimeter mercury, this is stage 1. And stage 2, this is 160 over 179 over 1, that is systolic, and diastolic 100 over 109. This is the diastolic. That is stage 2. And according to stage 3, if the blood pressure is 180 more than systolic and 110 more than diastolic blood pressure, if more than 110 or 110, this is called stage 3 hypertension. But now, in together stage 2 and stage 3, according to the JNC 7, that is stage 2. Now the classification and it makes more easier than before 1. But there is a stage 3 is also called, and according to the European Society of Cardiology, the stage 3 is still persists in classification of the European Society of Cardiology classification. So this is the classification, and we have to always remember this classification, because according to the stage of the hypertension, our management usually varies, our management depends. So we have to remember this classification. And this is the classification of the antihypertensive drugs. There are several groups. Like we also know that there's a first line antihypertensive drugs. We all know what are the first line antihypertensive drugs. I have already discussed that the first line antihypertensive drugs are the calcium channel blocker, the diuretics, ACE inhibitor, and ARB. So ACE inhibitor or ARB, diuretics, and calcium channel blocker. So what are the other groups of drugs? This is the beta blocker. We also say the centrally acting calcium channel blocker, centrally acting antihypertensive drugs. There are also, we also discussed that there is alpha blockers and alpha blockers, or there may be some direct vasodilators, also called some direct vasodilators. So diuretics, there may be thiazide diuretics, there may be loop diuretics, there is also called high ceiling diuretics or potassium aspirant diuretics like spironolactone amiloride. We all know that. The ACE inhibitor, we also know that captopril, enalapril, lisinopril, peindopril, ramipril, fosinopril. These are the ramipril, fosinopril, ACE inhibitor. And there were some ARB, angiotensin receptor blockers like losartan, candesartan, irbesartan, valsartan, and telmisartan. There may be some direct renin inhibitor, aliskiren. Actually, these groups of drugs are omitted. These are not actually marketed now. And it is not available also in the market due to its withdrawal. Calcium channel blockers like verapamil, diltiazem, nifedipine, felodipine, amlodipine, nitidipine, lassidipine. These are the calcium channel blocker. The beta blocker like propanolol, metoprolol, atenolol, both alpha and beta blockers. These are the labetalol, carfidolol, and alpha blockers. These are prazosin. I have already said that this group of drugs is usually given in elderly population or a population with benign enlargement of the prostate, like prazosin, terazosin, doxazosin, phentolamine, phenoxybenzamin. These are also centrally acting drugs like clonidine. This clonidine is available in the market. And there are some also alpha-methyl dopa. These are centrally acting central drugs, antihypertensive. There are some vasodilators, these are called direct vasodilators, hydralazine, minoxidil, sodium nitroprusides actually. And there are, we also know from pharmacology that there may be some sympatholytics like disarpidine, guanethidine, or there may be some ganglion blockers, pentolinium. Actually, these are not actually used as antihypertensive actually nowadays. So these are the classification of the antihypertensive drugs, and these are the according to the actually this is another way of classification like central acting drugs, beta blockers, calcium channel blockers, diuretics, and these are the mechanism of action actually of these drugs. These are the discussed here. We all know that actually in details, and we'll discuss if it needed later on. So what are the actually new evolution or new changes over the time from the GNC 1 to GNC 7 guidelines, or what are the recommendation changes over the time from 1977 over the 2030 up to the GNC 7 guideline. So in the earlier one, it is recommended that this high dose diuretics, actually in the early stages, we recommend the highest dose of the drugs. But nowadays, the recommended changes. Now a drug that we have to use the low doses of more than one drug, so we can combat the adverse effects of the drugs actually. So now we may need some combination drug to minimize the actually some side effects. Like GNC 1, that the recommendation was still the recommended was high dose diuretics. In GNC 2, GNC 3, these are the lower dose diuretics. That is some changes. No high dose diuretics or beta blocker. That was the recommendation in 1984. In 1988, the recommendation low dose diuretics, because high dose diuretics, it has got some several and severe adverse effects like hypokalemia, hyponatremia, weakness. That is a sudden fall of blood pressure. There's a lot of complications there. So they recommended over the according to the experience actually that physicians in that time the experience they gathered, or the research that suggests the recommendation is changes over the time actually. So in GNC 5 in 1993, the recommendation lower dose diuretics are beta blocker or ACE inhibitor, ARB, alpha blocker, or alpha beta blocker. in JNC 6 in 1997 recommend the individualized therapy. That is according to that we have already discussed. The patient should have some as is considering points already we have discussed. There may be some compelling indications. There may be some contraindications. There may be a stage of hypertension. So age may be considered. So according to the individual patients, a patient may need different types of antihypertensive drugs. So individualized therapy, single agent titration preferred, and low dose combo therapy as a secondary option. But over the JNC 7 in 2003, this focus on systolic blood pressure control. That is also important because if we don't control the systolic blood pressure, patient have increased risk of having brain stroke actually. Thiazide type of diuretics preferred as initial drug treatment. In that time, thiazide diuretics is recommended as first line drug above. But nowadays, thiazide diuretics, calcium channel blocker, ACE-inhibitor ARB, these are the actually first line antihypertensive. These four groups actually. And emphasis on combination therapy. There's low dose combination therapy is now recommended to avoid the complications, to avoid the adverse effect actually. So here I said that high dose monotherapy, actually the recommendation change over from high dose monotherapy to the low dose combination. So the recommendation is changes over the time. This is the JNC 8 guideline. Actually, the JNC 8 guidelines, this says that if the patient is suffering from diabetes or CKD, so first line drug should be ACE inhibitor or ARB if the patient is black or though the patient is black. So ACE inhibitor ARB should be the first line drugs. If the patient has got no CKD, no diabetes, no proteinuria, in that cases, we can choose any of the four groups of drugs like calcium channel blocker, like low diuretics, thiazide diuretics, ACE inhibitor, or ARB. Actually, these are the way how we choose an antihypertensive. This is the great. This is the actually grade or stage of hypertension. It is the grade of hypertension. Actually, it is depends on the European Society of Cardiology. And this is European Society of Cardiology recommendation, actually the ESC, and European Society of Hypertension, European Society of Cardiology recommendation in 2018. Here, if patient has got high blood pressure, high normal blood pressure, that is blood pressure is 130 to 139 millimeter mercury or 85 to 89 millimeter mercury. That is according to the JNC guideline. That is pre-hypertension. So there is a lifestyle adaptation, but lifestyle modification is needed actually in all cases, along with lifestyle modification. So we have to consider drug treatment in a very high risk patients. If the patient has got atherosclerotic cardiovascular disease risk factors, several reasons, so you can start antihypertensive drug. Otherwise, patient lifestyle modification is enough. If the patient is suffering from grade 1 to grade 3 hypertension, lifestyle modification should be given in all three cases. Along with that, if the patient has got atherosclerotic cardiovascular disease, CVD risk factors, in that cases, patient should be actually should have antihypertensive drug immediately. Actually, this is the classification. Actually, according to the American Society of Cardiology, American Society of Hypertension, there is normal less than 120 by 80 millimeter mercury, elevated 120 by 129 and or less than 80 millimeter mercury. But according to the American Heart Association, American Society of Cardiology, the stage 1 hypertension is called 130 to 139. That is below 140 millimeter mercury. That's 130 to 139 is stage 1 hypertension. That is their classification is a lower bit, that is 10 millimeter less than JNC 8 guideline or European Society of Cardiology guideline. The stage 2 hypertension if the patient has got more than 140 millimeter mercury and diastolic blood pressure 90 millimeter mercury. So I think this is the last slide I will discuss today here. And hopefully, inshallah, in the next day, maybe in the Sunday or next Sunday, or maybe in the Tuesday, we'll discuss next class of hypertension. So diagnostic workup of hypertension, what this means. If a patient came with hypertension, so how will you approach to a patient with hypertension? So we have to take details history of this patient. History is important here. So diagnostic workup of hypertension, the assess risk factors are comorbidities. We have to assess some risk factors of the essential hypertension, as well as we have to see if the patient has got any secondary causes of hypertension also. So reveal identifiable causes of hypertension. That is, we have to see if the patient has got any secondary causes of hypertension or not. So we have to assess the patient has got any target organ damage or not. And we have to conduct history and details physical examination, and we have to do some laboratory investigations. Number one, to find out the secondary causes, and number two is to see if the patient has got any target organ damage or not. So if that's to find out the secondary causes or not, if the thyroid function test should be detailed, kidney function test, urea creatinine, protein to see the microalbuminuria or not, we have to do the investigations. So even and also we have to see if there is other risk factors of ischemic heart disease like hypertension, like diabetes mellitus, like dyslipidemia. So lipid profile, diabetes profile, even some other risk factors, maybe homocysteine, maybe CRP level should be done. And also the patient should assess the hematocrit, lipid panel, serum potassium is electrolytes, especially serum potassium is important, serum creatinine, calcium also important, and also urinary albumin creatinine ratio, that is spot urine, is also important. So we have also to do the ECG, even the echocardiography may be needed to see the target organ damage. That is, usually we see that hypertrophy, that is left ventricular hypertrophy, may be found in the case of long-standing uncontrolled hypertension. So ECG is also important to see if the patient is suffering from any ischemic heart disease or not, or to have any mitral infarction or not, to confirm the and these are actually also the to see if the patient has got any target organ damage or not. We have even fundoscopy examination is very much needed to see the any hypertensive retinopathy or not, or kidney function, or cardiac function, echo or ECG should be done to assess the any patient has got any target organ damage or not. So actually these are the investigations we should do to find out any secondary causes, as well as actually to see the to find out patient has got any target organ damage, especially patient if patient has long-standing uncontrolled hypertension. So these are diagnostic workup of hypertension, and I think we can stop here today, and inshallah we'll discuss the next topics and the later on, because patient the hypertension pregnancy is also an important chapter. Secondary cause of hypertension is an important chapter. Hypertension emergency and hypertension urgency, these are also important. That is pseudo hypertension, but white coat hypertension is also an important chapter. And so I think we need several cases to complete the total discussion on the hypertension. So thank you very much. Thank you, AxisMedicalSchool, for giving me the opportunity to say something about hypertension. Thank you very much.